Good morning and welcome to the final day of Stroudwater Associates' 6th Annual Critical Access Hospital Conference. Over the past 2 weeks, we've had the opportunity to hear directly from rural healthcare leaders, executives, clinicians, financial experts, and operational advisors from across the country, all focusing on sharing practical strategies and real-world experiences relative to rural healthcare organizations today. At Stroudwater Associates, we work exclusively with rural hospitals nationwide. Our team includes former rural hospital executives, financial leaders, operators, clinicians, and strategic advisors who understand firsthand the realities of rural healthcare organizations and that they navigate every day. Throughout this year's conference, the focus has remained consistent. Practical conversations centered on sustainability, operational improvement, financial performance, workforce stability, governance, and long-term strategic success for rural hospitals and healthcare systems. We're grateful to everyone who has joined us throughout the conference and to the many speakers and organizations who shared their expertise and experience over the past 2 weeks. Today's session will close this year's conference with discussions focused on regulatory risk and revenue cycle performance. We begin this final day of the conference with a session focused on one of the fastest growing areas of concern for rural hospital leadership teams: physician compensation governance and regulatory scrutiny. As enforcement activities surrounding fair market value, Stark law, and anti-kickback compliance continues to increase, rural hospitals are balancing the need to remain competitive in physician recruitment while also protecting their organizations from financial and regulatory risk. In this session, Shad Ritchie and Megan Hazelton of Stroudwater Associates will be joined by Joe Thine, CEO of Southwest Health System, to discuss practical strategies rural hospitals can use to strengthen governance, improve compensation documentation practices, and create defensible physician compensation structures in an increasingly scrutinized environment. Drawing from both consulting and operational leadership experience, the discussion will focus on practical guardrails, real-world compensation scenarios, and approaches rural organizations can implement to support recruitment, sustainability, and long-term organizational stability. Please take it away.
All right, thanks, JD. We appreciate the introduction for sure. So again, we appreciate the time that everyone is giving us today and being on the COG conference. This is the last day of the COG conference, and we appreciate the opportunity to kick this off. Today, we are going to be talking about a topic that may not be the most exciting, but I do think we will be able to have some pertinent information with the folks that are going to join me today. My name is Shad Ritchie. I'm a senior consultant with Stroudwater Associates. Been here about a little over 2.5 years, but practical experience of about 28 years in the field with provider compensation. And with that, I will let Megan introduce herself.
Thanks, and I am Megan Hazelton. I'm a consultant with Stroudwater Associates. I've been with our firm for about 5 years now, and I focus on provider compensation and fair market value. And we also have one of our good dear friends here with us today, Joe Thine. He is the CEO at Southwest. Joe, do you want to introduce yourself?
Yeah. Good morning, everyone. I'm part of our executive leadership team serving as the CEO. Southwest Health Systems in a community of about 9,000 people in Southwest Colorado. Our service area is about 30,000, and if you were to look in the middle of 4 interstates, we're almost stuck in the middle, surrounded by mountains. So rural and geographically isolated, just to give some context. And looking forward to the conversation today.
Well, we appreciate you being on, Joe, for sure. And we know that, and hopefully everyone on the call knows that provider compensation is one of those topics that's highly regulated. So that's why we feel like this is a really important topic to discuss, but also we want to talk about real world examples and what Joe has gone through.
Yeah, so just before we begin today, we're going to talk about some of what our objectives and what we hope you all are going to get from today's session. So the first is really just a better understanding of fair market value and how it intersects with START law, the Anti-Kickback Statute, and any other regulatory requirements. Second is really a framework for evaluating compensation arrangements, really in a way that balances recruitment and retention goals with the compliance obligations. And third are some practical safeguards that you all can implement to ensure that compensation arrangements remain defensible over time. And as Shad said, we know that this isn't the most exciting content. So our hope really with having Joe here is that you all get some of his real world experience and, his experience as he has gone through some compensation redesign work. Next slide. All right, great. So we are going to start here with a poll just to get the temperature of the room. So if you all could please answer this poll question, which is asking how well your organization understands compliance and FMV considerations tied to provider compensation. All right, great. So it's looking like most respondents are falling in that moderately well, slightly well range, with a few of you saying extremely well or not well at all. We always find it interesting to see these results because in our experience, most organizations have some level of understanding around FMV, and the challenge usually isn't awareness. It's typically applying FMV principles consistently when those real world pressures emerge. It can be much harder when your orthopedic surgeon is receiving a competing offer or your only psychiatrist announces retirement to stay consistent within your policy that you've set. So thank you all for participating in that.
Yeah, we appreciate that for sure. It's really interesting to get that result. So the next piece that we want to talk about briefly is why is this topic important? And we already spoke a little bit about, compensation is highly regulated. And there's going to be some primary laws and statutes that we want to review quickly. Again, we don't want to go into too much detail, but as an organization, we go into, when we talk to organizations about compensation, a lot of times we do presentations to educate board members or provider groups on, does anybody know what START means? Anti-Kickback Statute. And I will have to admit, there are many times that we do this presentation and we ask that question, and a lot of board members, providers, they have never heard of these laws or statutes. And so it's a little concerning, but it doesn't mean that it doesn't mean education can't help with that. And Joe, just from your perspective, you've seen that in your past as well, right?
Yes, we often have board members that are not from a healthcare background, are unfamiliar with the regulatory environment. Their experience is seeing a provider as a patient, and it's almost starting from ground zero from an education.
Great. Yeah. So the first one really quickly is Stark Law. And what this does is it prohibits physicians from referring patients to receive designated health services payable by Medicare or Medicaid from entities with which the physician or an immediate family member has a financial relationship, unless there's an exception, and that exception is fair market value. So again, with Stark Law, this is a little tricky because intent doesn't matter. Even if you don't know that you're doing something wrong, you could violate Stark Law. It's a technical violation, and which could still be a violation. So again, when it doesn't fit, meaning if you're able to support fair market value, that's fantastic. But for Stark Law, if it doesn't fit, you're looking at civil monetary penalties up to $15,000 per claim submitted in violations, 3 times the improper payment, and potential exclusion from Medicare and Medicaid. So this is quite concerning for organizations when it comes to Stark Law. Doesn't mean we all need to sweat bullets and worry about it every day, but it's something that we need to be aware about. The next law and statute is the Anti-Kickback Statute. And this is a criminal law versus the Stark Law, which is civil. The criminal law that prohibits the knowing and willful payment of remuneration to induce or reward patient referrals or the generation of business involving any item of service payable by the federal healthcare programs. Again, this is to induce or reward patient referrals. So the core concern here is that compensation appears tied to referral volume or value. It doesn't matter what you call the arrangement with the provider group. It's how the contract is structured. And it always looks like you're paying for referrals, and that's the problem if that is the case. So criminal fines can reach $100,000 per violation. Yes, $100,000 per violation, and imprisonment up to 10 years, plus civil monetary penalties up to $50,000 per violation. So, and again, exclusion from Medicare and other federal programs as well. So this is really something that you as C-suite leaders, managers, and board members really need to understand, the details behind. The next item is the False Claims Act. And this basically coincides with the first two, Stark Law and anti-kickback. So any Stark or anti-kickback violation automatically becomes a False Claims Act violation. You don't have to treat these as separate issues. Sometimes there's something called qui tam provision, and this is dangerous because this is where whistleblowers can file suit on the government's behalf. This means that an employee, a competitor, even your own billing staff could report something that they are seeing within your organization. So if they are a whistleblower and it comes back favorable for them, they can receive 15 to 30% of the government's recovery. And that is, that's quite concerning because we want to make sure that we are doing things appropriately. So we want to, obviously, we need to make sure that, we inform our staff internally about, the reasons why we do things and why we comply with these regulations. The last one is private inurement. And this is specific to nonprofits. It directly is relevant to most rural and community health systems, as most of you are attendants today. This means that you cannot pay a disqualified person, which is an officer, a director, a key employee, compensation that exceeds fair market value for comparable services. So if you do, or if it is aware that you are paying above fair market value, then the excise tax could be up to 25% on the excise amount. If it's not corrected, it could be an additional 200%. So again, these are all really important topics for everyone to know on this call.
So we're going to talk here a little bit about the dollar amount. So the Department of Justice reported more than $6.8 billion in False Claim Act recoveries during fiscal year 2025, which is actually the highest annual recovery amount in history. And 83% of that, or $5.7 billion, was actually from the healthcare industry. And so, when we talk to rural healthcare executives and they hear that number, oftentimes the first reaction may be, oh, well, those cases involve major health systems and national organizations. And oftentimes that can be true. But what really matters is not the size of the organization. What matters is whether a compensation arrangement can withstand the scrutiny. And so most organizations aren't finding themselves under investigation because they intended to violate regulations. They're really finding themselves under investigation because the documentation was incomplete, the governance was maybe inconsistent, or compensation decisions evolved over time without appropriate review under fair market value. And so the lesson here really is not to be fearful, it's to be intentional. If you could go to the next slide, Shad. And so while a significant portion of the enforcement activity involves, Medicare Advantage, pharmaceutical companies, or large healthcare systems, physician compensation really does remain a major focus. And so the arrangements we are most commonly seeing receiving scrutiny oftentimes include, medical directorships, Could be call compensation, APP supervision payments, arrangements to retain your providers, certain recruitment packages, or any compensation arrangements where the compensation appears disconnected from productivity or work responsibilities. And so, importantly, none of these arrangements are automatically problematic. The issue continues to go back to documentation and fair market value. So, for example, if you're paying a physician $40,000 or $50,000 annually for medical directorship duties, the important thing is being able to explain what they're actually doing and being able to demonstrate the value of that medical directorship role if an auditor were to ask you about it 3 years from now. And so those are really the questions that you all should be asking yourselves proactively.
Perfect. Thanks, Megan. And we covered this briefly in a few slides ago, but the False Claims Act, again, is really important. Again, whistleblowers are now the government's most powerful tool against fraud, and 2025 pretty much proved it. What happened in 2025 was that there were 1,297 lawsuits that were filed, which is a 38% jump from 2024, and that was 940 in 2024. So that's accelerating. What this means is more and more people are understanding that they can, report them, an organization that they've interacted with. The financial stakes are massive: $5.3 billion recovered from these type of lawsuits. And so it really is important to know that your organization really needs to understand that anyone could potentially have some sort of, skin in the game when it comes to, are we doing things the right way or the wrong way? Finally, civil monetary penalties law. This is one of the government's key enforcement tools in healthcare. It allows the OIG, or the Office of Inspector General, to impose financial penalties for a wide range of fraudulent or abusive conduct without going to court. Basically, what's happening too is that we are seeing more and more organizations who know that potentially they are misaligned with some of these regulations, and they are starting to self-report. And the reason why people are starting to self-report, or organizations, is that it greatly reduces the damages. It can reduce your damages by 3.5 to 1.5 times the amount. So it's more beneficial to self-report than it is to have someone else, whether the government or a whistleblower, come in and identify that. So the OIG self-disclosure program had a large footprint in 2025, $2.43 billion in financial impact in 2025, which was a broad range of violations, and not just physician compensation.
Great. So we're going to talk a little bit more here about the rural impact, recognizing that rural organizations, you all are operating under a very different set of circumstances than larger urban systems. So Stroudwater releases every year an annual Stroudwater Rural Provider Compensation Survey report. And our most recent report is really showing that provider compensation is just continuing to increase across rural healthcare, which isn't particularly surprising. What is concerning us more in our survey findings is the variation in compensation strategy. We have a lot of organizations who don't have a clearly defined philosophy that is guiding those compensation decisions. And so when you don't have a standardized policy or approach, that's when decisions about compensation oftentimes become reactive. And so just a couple of examples here. You might have a family medicine physician who could receive a competing offer from a different organization close to you for $75,000 more annually. You have a decision there of, do you match it? Or you could have an orthopedic surgeon who's generating substantial downstream revenue for the hospital, but is appearing highly compensated relative to benchmarks. How do you evaluate that arrangement? And so the answer to these is, do you support this compensation? It could be. But each of these really requires a thoughtful analysis regarding the situation that you are in, and then documentation of that situation. And what we see in the most successful organizations is that they have a framework for evaluating compensation decisions before they even occur. And that really helps prevent that having to react to a decision because you already have that policy and your decision outlined. And Joe, I'd love to take a minute here to actually get your perspective, as a rural hospital CEO. What feels different when it comes to compensation strategy in a rural setting than, compared to a larger health system?
Yeah, I think you've been describing some of that, and we talked a little bit. It starts at an education level. So we mentioned the board earlier. Physicians and providers aren't often aware of or not thinking about some of the compliance issues. And my recollection is if there's a Stark or False Claims Act or other things, it can apply equally to the physician or provider who's in the compensation arrangement as to the employer. And so, providing that education not only to the board, but to providers is really important. The variation that you described, I think, is often true when you have providers that don't know the consequences, board members that don't, decisions to be made over time. It can be really easy to say, oh no, we're going to lose somebody if we don't pay them X, and not even understand what the market is, set aside the regulatory environment. But if you don't appreciate what the market is, that threat of losing somebody may not be as real as it's being purported, and or the ability to retain or recruit somebody in if that person is going to leave may not be as big of a risk if you really understand what the market is and what it takes to attract people in. So I think when we're not part of a larger system, it gets really easy to feel like we're on an island and we end up reacting instead of planning and being proactive.
Yeah, and Joe, the point too on the market is a really great point. We're going to talk in a couple of slides here about how FMV can really be more of an art than a science, and also incorporating those market dynamics into an FMV opinion as well.
Joe, just a quick question too, as an aside. Do you feel like once you educate members of your organization, or maybe those in the past that you've worked with, do you think they understand then better about regulatory compliance after you educate them?
Yes, and I don't often see like the details being recalled again, whether it's by board, physician, other key staff members. But I think what does happen with some consistent education over time and making sure we're talking about not only all the benefits, but all the risks that come with having compensation arrangements. Over time, at least our board and others I've worked with become aware so that when there's a discussion, they'll come back and say, oh, I do remember that's an important consideration. Or in small communities, we're all shopping at the same store. We're all at the same, sideline of a ball game. When providers and board members and community members are talking, at the very least, a board member is able to say, I think there's more to this than just are we paying you fairly or not? Or could you be paid more somewhere else? And it gets directed back to us as management instead of the board feeling like they have to react to a conversation that they're not equipped to. And quite frankly, it's not their role or responsibility to be in the weeds of an individual compensation discussion.
That's great. All good points.
All right, so we're going to talk a little bit about compensation strategy here. So if you could just take a moment to answer this poll question. Okay, great. Thank you all for answering. So one thing we have really learned from working with rural organizations is that compensation can become much easier to defend when everyone understands the philosophy behind it. And to understand the philosophy, you have to have a philosophy. But again, it's important to make sure that your board can explain the philosophy, your leadership team can explain it, and that even your providers can explain what your compensation philosophy is. Because if the answer to that is that none of those groups can explain the philosophy, then that can usually be an indication that your strategy needs some refinement. And a strong compensation strategy can really help your organization avoid making decisions just based solely on the crisis of the moment. So again, can kind of keep you from being reactive. So thank you.
And I will just,
oh, yeah, go ahead, Chad.
yeah, no, I'll just add that it looks like we have some folks that said that their provider compensation strategy is not clearly defined, and some say they're not sure. Please don't feel like you're alone in that. We see this quite often in a lot of organizations. So this session is actually to try to engage this audience and obviously to help educate on why is this important to think about. So real quickly, when it comes to compensation best practices, obviously, we recommend that you implement an organization-wide compensation strategy that aligns with industry best practices and fair market value. And that's a hodgepodge of things that you're probably asking, well, what does this mean? So there's a lot of different ways to construct a compensation model, and there's not one size that fits all. So some of the things that we have on the screen here, obviously, there's some annual guarantee component to a compensation model where you have a base salary, and then maybe you review that base salary based on productivity. And then there's some organizations that like to incentivize individuals on productivity, whether that be work or BUs. Or sometimes anesthesia has units called ASA units. So that's also sometimes if providers are financially motivated, that could be something your organization could put in place. Some two other items are obviously value-based compensation. We're seeing more and more organizations become part of value-based care with their contracts, and then just value organizations. And so obviously this could be a component from equality. And then finally, administrative and other duties. And when we say administrative, that could be medical directorship, APP supervision, call compensation, and there's other components to that. What we're seeing on average in a lot of our organizations, if they don't have good quality data reporting, we recommend don't go down that path until you do have good reporting. But then maybe you think about good citizenship, and that could be related to chart closure. Are charts being closed within the appropriate amount of time so you can bill appropriate for those? So these are just some examples of best practices to consider for models in the future. And Joe, I know you're thinking about all of these plus some, right?
Yeah, absolutely. I mean, what you described, I think if I take those poll results, we started our work a year and a half or more ago, and we started from a place of not being sure that we had a strategy, let alone being able to define it. And we're getting closer and closer to having something that incorporates many of this. And just like you were describing, we also unified our hospital and clinic electronic health record this spring. And so whether or not in the past we had good confidence in our quality data, we certainly didn't want to be measuring quality in a new electronic health record system and a new compensation plan. So we're looking at some retention bonuses that incorporate citizenship, as you mentioned, chart closures, documentation, coding audits, things like that ensure we're all doing good work and we're providing some incentives, and also getting providers used to the idea that there can be an incentive that's not tied to productivity, and maybe in the future that's closely aligned to quality.
Great.
All right, we are going to talk here about fair market value reviews. So, if you could just take a minute to answer this question about how recently your organization has obtained a third-party FMV opinion. There are no right or wrong answers with this question either, just more information gathering. Okay, great. So we're getting a couple of mixed answers here. So, a handful of you have been within the last 2 years. Some of you are 2 to 5 years ago. We have a couple who are unsure, and then, a group that says not recently or not at all. I think one thing that we would encourage everyone here to consider is viewing fair market value really as an ongoing governance process rather than just a one-time event. And that's really because, markets change, compensation changes over time. Just in the past couple of years, we've seen CRNA compensation, for example, change dramatically. And, your provider responsibilities change as well. And so your FMV analysis is really going to need to evolve as those factors change. So an opinion from 5 years ago is not going to adequately support today's compensation arrangement or market environment. And so regularly reviewing those really helps identify issues before there becomes any problems.
Yeah, good point. And one other just quick snippet is that FMV reports or analysis does usually have a shelf life, and usually they're good for about 2 years. And so definitely if it's longer than 2 years since you've had an FMV and you're concerned about compensation for a particular provider, it's always good to get a third party to review that.
Yeah, and so here's really just some things to consider when you are thinking about compensation, just some best practices for us to offer you. Going back to, market dynamics and some of those factors that impact compensation arrangements. We often say that FMV can be more of an art than a science. And that's really because two physicians could be in the same specialty, but really have different FMV conclusions. So let's say, for example, you're recruiting the only orthopedic surgeon within a 75-mile radius. Your community has significant outmigration. You have patients waiting months for appointments, and you've been trying to recruit and have been unsuccessful for 18, maybe even more, 18 months, maybe even longer. So the question here is, could compensation exceed benchmark medians? Absolutely. But this is where your documentation becomes critical because your documentation needs to tell that story. It needs to explain how long have you been recruiting? What does your outmigration look like? What is the impact to your community? What is the experience of this provider you are trying to bring in? All of that plays a role into FMV, and that's why we say there's no two FMV opinions that can be the same. And so just keeping in mind that you really need to be able to tell that story. And then just this on the right-hand side of this slide, we always recommend that you have FMV opinions documented and saved with your physician's contract, especially if that compensation does come out to be greater than or equal to the 70th percentile of the benchmark that you're using. Or if your compensation to productivity is greater than 10%. So again, looking at that compensation to, work RVU productivity or ASA unit productivity if it is an anesthesia provider. So Joe, I'd love to just ask you a question about this. So, when you are talking to your providers, how do you explain the FMV considerations to them? Especially if your providers may only be seeing, what a neighboring organization is offering a provider in the same specialty as them.
Yeah, I think there's a couple things. One is, as a community hospital, we try and really share why we exist. with providers. And the whole reason we exist as an organization is really to improve the health of people that live here. And one of the ways we do that is through the relationships we have with physicians to improve access to high quality care where people don't need to go somewhere else. And so we ground the conversation, and then how do we align our providers with that goal of the organization, and how does compensation serve as a vehicle? And when we think about neighboring hospitals, at least for us, the next nearest community, if we were to be looking at fair market value, it has a much higher cost of living. If you were just to take housing as a proxy, the median price of a home in the next nearest community is north of $750,000. It's starting to approach $1 million just for the median price of a home, where in our community, the median price of a home is sitting closer to $325,000. And so I would expect a physician who's working in a community that has a much higher cost of living to potentially earn more for the same amount of work. And so we choose to center ourselves then around what is a market that looks like ours, and we try and attract people that want to live in a community that we serve. And if somebody's looking to do work that's not like for a community like ours, actually on the recruiting end, we would prefer to let them go somewhere else, because we don't view that we should have to pay a premium because we're a rural community relative to an urban or a resort community. We're willing to pay a premium to bring the right person here who may choose a different rural community. And that premium might be a small amount relative to other rural communities, but it doesn't need to match what effectively is a different market from the market that we're in. Does that help answer your question, Megan?
Yeah, it does. I think it's really helpful too, just of, making sure that, no two communities are the same. It's not an apples to apples comparison, and being able to have that conversation with your providers and obviously listen to them and understand their concerns and where they're coming from, but then also, making sure that they are able to recognize the difference in the organizations or the community itself.
And Joe, those are not always the easiest conversations, right?
No. No, when you're close enough that your kids play ball against each other, during the season, like people end up on the sidelines and it's like, wait, I make this and you make that.
Yeah.
And interestingly, sometimes when we've had a specialty, as you were describing, that we really need in the community and needs to be here, there have been moments where we're paying a premium for an individual relative to the next nearest community, and that next nearest community, their physicians are asking, how come they can't earn as much as what we're paying? But again, the work is different. We may have a solo physician doing a lot of work for us, call coverage and other things, where that work is shared in a group of 4 or 5 physicians in the next neighboring community. So that conversation works both ways. And if you don't have a rational approach to why we're doing what we're doing, those conversations get even harder, Shad. They don't get easier.
Oh, for sure. For sure. And before we get into the final fireside chat, and I'm going to tee you up a little bit, Joe, on this one. Think about, while I go through this slide, why did you all decide at Southwest to embark on a compensation redesign? So, when a compensation redesign process, when an organization identifies, well, we have too many variables, we have a lot of differences in how we're paying providers, and it doesn't match industry data. We know that compensation redesign cannot happen overnight. It's a process. And so what we suggest on this slide is basically there's going to be a stage of events that need to take place before you can roll out any type of new compensation plan. Obviously, education to all parties is going to be really important. Data collection and verification, providers are totally data driven. So it's really important for providers to understand and see transparently data. And then you want to benchmark your compensation and productivity to industry data. We highly recommend having a compensation committee that does include some of your key providers that could represent the organization and not just themselves. and then look at interview key stakeholders, get their input on what they're looking for. So are you going to develop a program that's going to recruit and retain? And then finally, you're going to develop an organization-wide methodology that's really going to, if you do it the right way, it should have, it should last, several years versus 1 to 2. So with that said, Joe, I'm just going to kick it off. This is what we call our fireside chat. And I'm just interested, when you came to Southwest and you had been at other organizations, what did you identify in terms of provider compensation, and what led you to the direction you went down?
Yeah, great starting point, Chad. So interestingly, the thing that drove us to look at this was not a concern around fair market value, although we wanted to make sure that that was going to be the place that we landed, and we certainly didn't want to find ourselves at risk. But what I found was many of the physicians and advanced practice providers that we employ didn't understand their own compensation structure. And the reason they would not understand it is they talk with one another and they'd say, why is this person being paid this way and I'm being paid that way? And it seems like we're doing similar work. And so took a little bit of time to actually go look at contracts, whether they were up for renewal or not, just to get a sense of why would physicians and advanced practice providers feel that way. And looking through our contract history, it became really evident that there wasn't a strategy that I inherited around compensation. And some of the things you described earlier likely had occurred. And depending on what the need of the community was, what the pain points were, the hospital worked really, really hard to retain people and used compensation as one of the biggest levers to do that. And so we ended up with just no uniform way for compensation. And it caused us to say, boy, if we do in the long run want to attract and retain physicians, they need to both understand their own contract and their own compensation, but they also need to know that it's not only fair in terms of fair market value, but it's fair compared to the people that they're working with every day, and that they can all understand what they can do to have flexibility if that's what they want, to earn more if that's what they want, and that it's in a consistent approach. So that's kind of our starting point for really looking at this.
And that you said that started about a year and a half ago?
Yeah, I mean the kind of curiosity about how did we get here and what do we do was probably 2 or more years ago, but making the decision and making the commitment to say we are going to develop a strategy, we are going to align it with the goals of the organization and being able to sustain things over a long period of time, have a compensation package that does attract people and does give them a reason to stay. That material work really started just around a year and a half ago.
Yeah. And then obviously as a C-suite level, along with your CFO and other leaders, obviously when you're talking about compensation, that's one of your highest expenses across the organization. So is that something that you had to consider or are considering when you're developing a new plan?
Yeah. So one of the things we did before we even dove in to the nuts and bolts of creating a plan, we in aggregate looked to see what is the total compensation, regardless of form, that we're paying to providers today. And in aggregate, how does that compare to the market for like providers doing similar work? And what we found was if we were to go provider by provider with that variation, some were earning more than the median, some were earning less in total compensation. And as we planned financially for our current fiscal year, we started asking ourselves, what do we think our capacity is going to be to get providers for, again, like work to at least the median compensation? And then how do we not harm those that may be earning more than that? And so we started with a budgeting exercise so that by the time we got to the end of last year with our board, we had a plan for what the financial commitment of the organization would be And then a lot of our work towards the end of last year and going into this year has been, now given that financial commitment from our board and the organization, how do we structure compensation?
That's great. While we pause for a second, I will just let the audience know that if you do have specific questions for Joe specifically, and or Megan or I, feel free to put that in the chat. We're happy to answer any of those questions, because we really want this to be interactive. If you have a challenge, Joe probably has tackled that one at some point in his career, but yeah, we would love for you to ask any questions specifically.
Joe, I'd love to. We talked a little bit about, incentives, and I know your organization is incorporating some incentives as you go throughout this process. In rural, we can often see, provider productivity fluctuate or look very different from, some of the industry survey data that we do have when it comes to national benchmarks. How have you, thought about that, or how has that kind of driven or influenced your thought process around your compensation, how you incentivize your providers?
Yeah, and great question, Megan. And I think it's going to vary a little bit. And so, maybe tackle things in a couple different blocks. If we're talking about clinic-based providers that are not taking call, they don't have other duties that, may have some other form of compensation attached. Our general approach has been that we want to pay at the very least average compensation at a base for similar work that's being done nationally. And if we can have a base compensation and productivity that match, that gives us the best chance that we're aligning with the organization's reason for being, and that it will be sustainable. It also gives us some room on a fair market value to say what other things are really important. If the base salary and productivity and the productivity compensation all align close to a median level, it allows us to say what other retention bonus could we provide. If we're recruiting somebody in, what can we do on a attracting, one-time bonus for sign-on? What can we do for student loan payments? Those are all forms of compensation that go into that total. And so by starting with a base and productivity that match at a national average, we end up paying more in total compensation than the national average, but we've given ourselves room to listen to the physicians and APPs and ask them what's important to you that we can compensate for. And so part of the work we're doing right now is just that, is deciding of the things that we could do, what are most important to the physicians that we can financially bear, and building that in. The other place is, gosh, in rural communities, if we said we're going to tie everything to compensation and productivity, I think we'd find ourselves running afoul in sometimes in places trying to attract or retain people. The easy example for me is our surgical specialties. There are some areas where we want to have 24/7 call coverage. Again, for the people in the community, that's really important to us. But if somebody were working in a busier hospital in a busier community, the days that they're on call, they would generate more care and more work RVUs. And so that balance of compensation to work RVUs would be more like the national average. In our case, if we just paid on productivity and expected somebody to be on call, that compensation would be lower than what it would take to attract and retain somebody here to be on call, because we may not have that same volume. And so we expect the total compensation to be market competitive. But when we look at compensation relative to work RVUs, we know that compensation to work RVU is going to be higher. And again, we have a reason to do it. We can communicate why somebody's comp to work RVU for a call specialty may be higher than a comp to work RVU may be lower, or closer to the national average for a non-call provider. So those are ways that we're thinking about and working on that structure.
Yeah, that's great. And how do your providers feel about the productivity incentive? You might have some specialties might be more interested in it than others, but one thing we've seen with a lot of the work that we do is that it can really be a mixed bag about, in a provider preference. It's just changes based off of your community or your provider. And so what has that experience been like for you?
Yeah, Megan, I think you described what I've seen not only in this role, but in other roles I've played in my career. And I think this is true for all of us as human. We all show up to our professions with different things that are motivating us. And I think that's true for physicians. Some are looking at, boy, how can I maximize my financial compensation in a package? And if the incentives are right and they're aligned from the organization and improving access, and the what we're doing is achievable, and somebody who wants to improve access can earn more, there's great alignment there. Sometimes people, that's not the most important thing. They want a stable income and they want to make sure it doesn't fluctuate. And sometimes that can be a little bit harder in terms of, like, what's the minimum access that patients need for you to earn what you believe is your stable income. And so occasionally, there's conversations that are really about why we exist and what's important. And then part of it is, how do we support all of those providers so they can achieve what they want? If we, and I would say none of us are perfect in terms of creating the best work environment and all the efficiencies that one could have. But if we're working hand in glove with the providers that are delivering care so that they can improve access, because we're supporting them on other parts of the workflow for patients to come in, then we can get alignment, whether it's I know I can meet a base level and keep a steady income, or if I want to do more, I know the systems, the process, and the people are going to be there that enable that. And I'm willing to stay here because I know I can accomplish either of those things. But that requires operations to be engaged and understand, what the motivations of each provider are, and understand how their compensation ties to our ability to serve our patients.
Great. Thanks, Joe. And I see JD popped on, which means we're running up against
Close to time.
You've still got some time. I'm just here because I need to supervise.
So, Joe, we did get a question that I think is actually really interesting. And so this is something where can kind of complicate a compensation redesign process. And what that is when you have contracts in all ranges of renewal, how do you start that conversation, and what expectations do you set so you don't have a mass exodus on your providers as their current contracts come to renegotiation?
I mean, that's exactly where we started. And so, again, a year ago and change, when we started working closely with the physicians, we brought them in from day one. One of the things we were able to see in setting a financial budget for this year and thinking about the long run was we were in a place where we decided that we wouldn't take anybody backwards and we wouldn't force anybody into a new contract on day one. And so that allowed people to, I think, take a deep breath from day one and realize that we were not going to force somebody, if they like their current compensation arrangement, to change today. We're also pretty clear, like, we need to make sure we can sustain everything over a very long period of time. And so it doesn't mean that we will be able to hold them in that contract in perpetuity. If somebody's earning more, and it's not going to fit in with our comp plan in the future, it may be that in future years, as the market continues to accelerate in compensation, that things catch up, and in a future year, they're like, ooh, that new comp plan looks really good. And or the financial sustainability of the hospital may change, and we may have to have a hard conversation and come back and say, in order for us to provide all the access that the hospital needs, we do need to align your compensation with the plan. So we've given ourselves some breathing room, and really more than the dollars and cents, it gives the space for providers to show up genuinely with their thoughts and concerns and partner in the conversation without feeling fearful that they're going to be forced into something that would not be what they could agree to.
Great, thanks, Joe. And we have like a minute and a half left, so I am just going to see if you have any parting words of wisdom that you would like to provide any of your peers who are in a similar situation as you.
Yeah, I'll provide one piece and a story to go with it. I think we can be fearful as well, right? Just like you mentioned, what if a physician is uncertain, unclear, they're afraid of the unknown, what's this going to look like? Those administering the compensation and entering this can be afraid. Is this person going to leave? What happens, et cetera? We have completed the rollout of a portion of our compensation plan for a group of providers that are of a similar specialty. And what we found for a subset of that group was that the compensation we provide today fits within the market. And again, the way we've designed it, it's actually a little bit higher than the median, given all the things we're compensating for. And we had a couple of providers in that group that said, ooh, you're not going to be able to attract anybody to come do this work. You might not even be able to retain everybody who's here today. And we had enough confidence in the plan and all the work that we did that we felt like we would be able to recruit and retain people. And this was all in the midst where we actually had an opening. Before we started this work, we knew we had an opening, and we just held to the process. And when we finalized that compensation plan and we were searching for a provider to fill it, we actually had more providers applying than we had a position open, willing to relocate from other parts of the country with the compensation plan we developed. And we were able to go confidently back to the group and share with them that compensation is attractive. There are people that are willing to work here. We didn't lose any of our providers, knock on wood. We haven't lost anyone through that process. To Shad's point, there were very difficult conversations through there. There was a lot of education on why we believed that we were fairly compensating people. And at least in this initial transition, the work we did has stood the test of time. There were moments where I was afraid, gulp, what if we aren't able to retain some really good providers that we want in the community? And at least to date, holding to something that we could communicate clearly, that everybody can understand, everybody is compensated the same way, has really stood the initial test of time.
Thanks very much, Joe. And thank you to Shad and Megan for an insightful discussion around physician compensation governance, regulatory risk, and the operational realities rural hospitals are navigating today. As a reminder, when you exit today's session, you'll receive a brief survey pop-up. We'd greatly appreciate your feedback. It should take less than a minute to complete and helps us continuing to improve our conference programming each year. If you'll be joining us for our final session of the conference, please return to the conference lobby and select the next session from the agenda. We'll begin again at the top of the hour. Our final session of the conference will focus on revenue cycle leadership, accountability, and financial performance improvement in rural healthcare organizations. Thanks again to the three of you for a great presentation.
Thank you.
Thank you all.